you like Jill to pull it up for someone?
I will be happy to pull it up. Let me find it.
And I think we're just going today. We just kind of a quick reminder of where we were at and kind of taking a look at the items that we had left to finish up on the main sheet. So I think that was it on the agenda, wasn't it, Jill? We didn't have any other breaking news.
No, we didn't have any other late breaking news, but since you asked for me to share my agenda, and you would think 3 years after doing virtual meetings, I would be so much better at this than I actually am, but I'm not. So I'm going to practice here for a moment. Here we go. Are you ready? We're going to pull up the agenda.
I'm ready. And then
All
after we
right.
see the agenda, can we pull up the sheet?
Yes, let me get this out of the way there.
Cool.
And here's our agenda. So you're right. We only had the continuing on the treatment goals and themes document that Jill Archer had started. And if everybody remembers,
Yep.
the point where we were was trying to talk about each of the items that people had listed, trying to figure out kind of like, is that a federal item? Is that a state item? Where that item lives? Like, where would you have to go to accomplish it? And because we are a state agency and this is a public meeting, we are required to put public comment on there, but I don't believe there are any members of the public. And that was it.
No. Yeah, great. Well, thank you so much, Jill. Appreciate that. I guess with that, we could just, unless people have new business of any sort that they'd like to put on the agenda, we could just dive right into the document and keep chugging along on that. Okay, let's do it. I see a consensus of let's get it done.
Okay. All right. 1 second for me to pull up I've been calling it Jill Archer's document.
She did a great job of consolidating it. I feel the pressure is on, but that always is with Jill. She's such a high achieving lady.
Jill, are you looking for the goals?
All right. Let me pull it up. And then all of you should see it right there. And then let me get to the point where we left off, which was, I think, right about here. So
it was
here,
it wasn't it identifying persons, or did we not quite make it there? Oh, capacity building. And I don't think we have.
And if I remember correctly, Heather, the person who put this item, the Washington County CAT project, isn't here today.
They're not here. Yeah, that's what I was just thinking. I don't see anyone from Washington County here. It was Kirsten, wasn't it?
Yes.
Because I know she was working on that program. Yeah, and I haven't heard anything because I know some of our members are part of that. And last I heard is they were still looking for some funding for some bits and pieces of it, but it looked like it was still moving ahead.
Okay.
But that's all I've got on that one. And then the rate increases, I can tell everyone that those are rolled out and it is completed. And what we're doing at OCBH, just for you guys to know, is as part of requesting from the legislature those rate increases and getting the support for that, Oregon Council with some of our other partners, including AOCMHP and the Oregon Alliance of Children's Providers, we did a rate study, or not a rate study, what am I saying? We did a salary survey point in time study. And MACBO, also we compared that to some information we got from MACBO, which was great. And that way we got a salary of what people were paying, what their underfill percent was of positions, turnover rates, and then what they felt was the competitive market rate that they wanted to get to help them retain and recruit staff. And so we just requested that from our members to do it again. We'll probably do it if not every year, every biennium in our membership. So I will have comparative point in time data very shortly. So we're excited to see what the impacts of the rate increases are. Early trends look like less underfill. So that's exciting. More positions filled. And also keeping up with inflation a little bit. So so very exciting. We're actually seeing the amount of employees slightly either at pace with pre-COVID or slightly above. So we're super excited about that too. So all good outcomes that have come from the investments in the rates for the workforce. So we're really we're looking forward to that, but we'll have more detail to come. Low barrier buprenorphine. And the Boulder Care folks aren't here, or was that something that we just brought up? Boulder Care. Jill, do you remember, or anybody?
I don't remember.
Nope. Okay. Okay. I do know, and anybody else chip in too, that the feds have removed the waiver program, so nobody has to get a waiver anymore. So this is kind of old news, actually. So we have a different challenge. The new challenge is since there's no waiver, any physician, as long as they take the required CEUs, can prescribe.
Mm.
So I have thoughts about new challenge with that. Does anybody else have thoughts of new challenge with that we might want to prepare for?
This is a thought that's really high level, and I'm not a clinician. So I've seen in primary care environments and obviously the treatment centers that low barrier is just really difficult. And I think changing the culture to provide, buprenorphine, like drug only, without a required behavioral health service, is probably something that we might want to acknowledge. I don't want to make a judgment like clinically of like what's best practice. But my understanding with low barrier is that you can go in to a facility and get your buprenorphine prescription without a requirement to go to a group or a counselor. So low barrier because of insurance and low barrier because of physician training requirements seems to have improved, but I'm not really sure about the lay of the land that requires like ancillary services.
Did you have something too, Christy? Oh, you're on.
This one's difficult for me. I worked MAT for 6 years as a clinical supervisor. And I'm a harm reduction girl. I get it. We want to get the product in the hands of people, that it's going to save lives, but without that mental health piece, without treatment, I don't know. I mean, I get it. It's about saving lives, but we're not getting anybody better. We're staying at a status quo. When you don't have mental health services, treatment to go along with it. Because you're not addressing any root causes, you're not addressing trauma, you're not, I go on and on and on. But I guess step one is just, I worry about it. I worry about physicians just handing out prescriptions and not quite understanding how BUP works. Is it BUP or does it have a blocker in it? What are they prescribing? Because there's two different kinds. There's a ceiling effect on BUP. It's not going to work for people taking fentanyl. BUP's not going to work on them. Because you can only go so high. They're going to need methadone.
Right, and the induction is so complicated. So
it's so complicated. Yeah, it's there's a reason that we've required the waiver was there, because it is so complicated. The other thing with BUP is people are gonna lie to their doctors and tell them, no, I haven't used, and they're going to go into withdrawal just like that. I've seen it happen. It looks like somebody's dying.
And the doctors don't know.
Yeah. But I guess we have to look at the positive, that it's a step in the right direction. But how do we get that information out there and provide those other services that need to go along with the medication?
And maybe understanding,
yes,
really understanding what it means to offer MOUDs in primary care.
Yes.
You guys, those are all my same things. So I don't know, in this recommendation, since we all have the same concerns, I don't think we would be unique to if we had a larger group today. I think people would probably have similar concerns. Is an opportunity and concern with this is I wonder in the plan if it makes sense in focusing on kind of addressing some of those things is creating some kind of education echo or hub for physicians about what buprenorphine can and can't do. What are the how to develop partnerships with community-based care so they can ease access to other outpatient services. And like the ECHO should have that kind of training, partnership training and connection and real hands-on warm handoff to local providers. And then I think the other big one, like you guys were just saying, is we know with fentanyl that really buprenorphine is not a best practice, it's methadone. And so how to use this as an opportunity to train people about fentanyl, because we're just not ready as a state for fentanyl. We're just not, the professional community is pretty clueless, honestly. And we've been putting on a lot of trainings here at OCBH. And it just has reminded me that we've been doing a lot of intensive, what we thought was intensive training for a year, and it's not enough. So that was, it was a good reminder for me because we were feeling like we were really rocking it. And it's just not enough. It's not enough training because the rapid increase of fentanyl on the street market is just, it's just over the top.
So Heather, I'm putting in the chat, and maybe people on the call have participated in the OHSU addiction medicine echoes. They're a really great source of information on BUP. Have you attended any of those, Heather?
I usually don't because they're usually geared to physicians. And so I just haven't. I know some of our members, medical directors attend them because they have the last few years, they've done a good job of expanding into the substance use disorder curricula and support. But yeah, maybe maybe part of the ADPC plan is to check in with them and help them be more robust to address this issue.
I work really closely with the ECHO director at OHSU. So
great.
I could I could invite him to one of these meetings too. And he could get feedback. Like he's awesome. And he's really expanded the topics. Like they just finished a jail healthcare echo, which included a lot of people who weren't necessarily physicians, but they were engaged in providing care. So, I mean, I could see the development of an echo that goes beyond physicians to talk about kind of what kind of supported services are needed in primary care.
Absolutely. That'd be great.
Because it seems like it's going from one extreme to the other, right? Like you can't have MAT unless you're going to 10 groups a week, or you can go to primary care and just get a prescription.
Absolutely. And we need the middle. I agree. So just trying to think about what we could leverage. And I love the ECHO model. And I think we could really leverage that in the state because people are comfortable. More people are pretty comfortable with it. And we just can't have too much frankly, with fentanyl, we just can't have too much duplicative training. We need lots and lots of duplicative training so that people can keep accessing it. Yeah.
If you want, I could invite Dan Hoover, Dr. Dan Hoover, he's addiction medicine physician. I could invite him to one of these meetings to talk about what he's doing and then get some feedback for how an expansion might work.
Yeah, I'm okay if you're okay, Jill. I think that's a good idea.
I think that's a great idea. Actually, that's exactly what I was just about to say, Heather and Liz. I'm making a note that Liz, I will connect with you about your contact, about seeing if he will come in and talk to this group at a future treatment subcommittee meeting. That was a lot of words, Liz, to say, I will connect with you about your person and get him on the agenda.
I know what that means. So we'll get Dan to join the Zoom.
Oh, cool.
Okay.
Yeah. And then on this topic, I mean, we're doing a lot of training here at OCBH, and I know all of us are aware of different kinds of training, and MacBo does training, and you're connected to a lot of training, Liz. I think just all of us to continue to share with each other so we can distribute across our various communities and email lists, because we're just so not ready. Yeah, and I've just been hearing from all of our members across the state in the last month, significant increases in overdose happening on site in waiting rooms, so I'm sure the levels of fentanyl in the street have, as we expected, are continuing to increase. And it was pretty shocking right before I left on my trip. I was called within 4 days, I was called by 5 of our members. That tells me if 5 people reached out to me that things are not good. Yeah. Because not everybody reaches out when they start having incidences because they're too busy, but I did. People are like, what is going on? I'm like, oh, we've been waiting for this. Okay, cool. All right, well, that sounds good. Does that feel comfortable for folks for next steps on that one? Okay.
Mhm.
And that covered the next one too. Okay. Cool.
Right. We will go down.
Okay. Identifying persons at risk of experience health, social, legal consequences from alcohol and other drug use, providing them with intermediaries to facilitate those services, and ASAM training. I was just talking to, the thing that came up for me on this one is I was just talking to Nicole Corbin's team members about this, because this is a SUD waiver item. The ASAM training was part of that. So I can share here what I shared with them when they asked me about it, of what's the most current thing I think happening through them. They were really trying to figure out who to train on ASAM with the SUD waiver implementation. And then I guess maybe this touches 110 too, maybe.
Mhm.
But the ASAM training that they're looking at bringing in ASAM training through the Oregon Health Authority. So I suppose we'll have to help them market it when they're ready. And I don't know. You tell me, Christy, what you think. I feel like our clinicians and CADCs are pretty well trained, especially if you compare us to other states, because we've been doing ASAM for 30 years, and there's always room for more training. Don't get me wrong, but you guys do a ton of training, and even yeah.
There's some talk. So we require, it's a core course.
Yep.
For the CADC, we require at least 6 hours of ASAM training. Most people get more because they go to community college for it.
Yep.
But we have other requirements for renewals. Like right now, you have to have 2 hours of suicide prevention. That's state law. We have to do that. You have to have ethics. That's our rule. Something like this, because it's so prominent, might be something that we need to talk about adding. Every 2 years, you have to have a training. It's so important. We've got to get those levels of care right.
Yep.
And I think that it's misunderstood.
I think people get accustomed to what they do instead of what's appropriate. And then there's the new ASAM criteria is coming out shortly. So maybe that's a good way for you guys to roll it in.
Yes. So I think that's something that we could implement in the next couple of years. The other thing we're doing, then this is brand new, but I think this will coincide. We've got supervision problems out there. We have CADC2s and CADC3s that they don't know how to supervise. They don't know that there should be, just because somebody took a class, you need to be teaching ASAM on the job all the time, for years. So we're looking at, I took the clinical supervision exam, the national credential this week. It's an excellent exam. And we're looking at adding an add-on certification. It won't be a standalone. You'd have to be a CADC 2 or 3 or an LPC LCSW. Take the clinical supervision exam. Then the LPC LCSW can sign off on documents. But the exam included a lot of ASAM. I was surprised. It was a lot of ASAM, a lot of theories.
Yep.
And I think if we can get that supervision piece tightened down a little bit, let people know supervisors need to understand what they're supposed to be supervising, and ASAM's a big chunk of that. So more to come.
Well, I love that, Christy. And I asked Nicole's two people, I can't remember their name now, I'm so sorry, to reach out to you because I knew that you guys were working on. Did they reach out to you?
I haven't heard from anyone yet. But maybe I have. I get a lot of emails. I talk to a lot of people. We have 15,000 members now.
I know. Okay, well, I'll remind them, but I told them they don't have to reinvent the wheel, because the other thing in the SUD waiver for ASAM is a lot of the ASAM stuff in the SUD waiver, if the CCOs aren't using it for the utilization management component, it's not going to do a lot at the systemic level. And so I was like, yes, please invest in ASAM training for CCOs, because they're not familiar with it and their staff is not familiar with it. And I don't know so much from the hospital side, Liz, what you think, but I do know that ASAM is doing their best to go robustly national as they possibly can. And so an example is just through my national council stuff, I know that 4 states have gone full ASAM, similar to our trajectory that we've done here in Oregon for several decades in the last year. And I expect that trend to continue. So because the ASAM is just, no tool is perfect, but it is probably the most robust tool we have out there. So, and they have the gravitas to push it through in lots of states and federally. So, and I see SAMHSA they've always kind of pushed it, but I see them promoting it more in their language and things. So I think that's a big piece of the ASAM training. And so OHA, too many O's, OHA, they were trying to figure out which kind of areas they needed to kind of fill the gap for training. What, Liz, did the hospitals, are they using ASAM pretty robustly?
I don't know. I have no idea. I can ask if that would be helpful, but I have no idea.
Yeah, because I know that on the medical side, and that was the problem with the CCOs, is some of them were asking our providers and thus putting the burden on the consumers to use a different tool because they were more accustomed to that tool from the physical health side. I can't remember, there's a couple different ones that they use more on that side. And then because the ASAM is in the OARs, some of our agencies were having to literally do 2 assessments with a consumer. How unfriendly is that? And just always just doing this weird stuff to fulfill bureaucratic stuff. So that was one of the really exciting things about the waiver, was getting the whole system aligned to ASAM. Yeah. Well, maybe if you can poke around and find out, maybe that's another training area gap for them. So
Heather, specifically for which jobs? Is this for like CADC or including like prescribers?
It's everyone. ASAM ASAM is for everyone. So it's that level of care tool that you do a screening and assessment. And it's for addiction med docs. I've
never actually seen anything else used. But never had this conversation before. So I can ask if there are competing tools. I mean, is that the question? Are there competing tools that are being used in the hospital, and are people trained up? I thought you had to have a certification to administer the ASAM.
No.
Or just to diagnose a use disorder. Okay.
Nope. You don't. And then anybody under a CADC can you do the screening tool.
Okay.
Yeah. They've made it to be a whole system tool. Is that a good way to say it, Christy? Yeah.
Yeah. I mean, anybody can, you're not assessing, you're using the tool, and then the CADC is giving the diagnosis and reviewing the assessment. But it's the same in mental health. QMHAs technically don't assess, but they do the assessments. So yeah.
So that's what I know is OHA is kind of fussing around with trying to figure out where the training gaps are on the ASAM. And so that's just what you guys are talking about. What I just shared is what I shared with them, that I knew for sure that there was a training gap on the CCO side, that they should probably, my recommendation to them was lean into and check with Christy at MacBo for the certified provider level side. And, and I love the idea of that test. That's awesome, Christy. How cool is that? Especially for the master's people. So they can get certified.
We had to make Eric think it was his idea, and then he just went with it then. So
This meeting is being recorded.
oh, he knows.
He knows. He would laugh at that.
So Christy and Liz, just to make sure I'm capturing this correctly, Christy, we talked about possibly making ASAM training a requirement every 2 years.
Yes.
Did I get that right?
Yeah.
And then
And that would just be for the CADCs. I don't think we'd require it for the mental health credentials.
Okay.
Yeah.
Okay. And then Liz, you're going to check to see if hospital personnel are using ASAM and if they're
And
using
if there
other
are training
tools.
gaps, yeah.
And if
So
there's training
I know they're using
Okay.
ASAM, so I'm gonna ask about, just making sure I've got this right. So I'm gonna ask about competing tools, and I'm gonna ask about training gaps for people who are using the ASAM tool. Okay,
Yeah, because the other thing that I believe OHA team as part of the waiver is going to make available is for community behavioral health folks. They're going to provide some funds to implement the full ASAM continuum tool if people are interested in doing that, which has a lot of interesting opportunities with it. It also, like every IT platform, has its challenges, but it does have some interesting opportunities in it too. But that's all I know about where ASAM is at. And Jill, I'll get you the name of I apologize, I cannot remember the name of the two staff that are kind of leading, Nicole's staff that are leading that.
Okay, no problem. And I know there are so many new people at OHA. I probably can't name them myself either.
Yeah, yeah. So anyway, it was the nice. It was good conversation. So
so Sam just moved up, right? Like last week?
Sam is interim for Jesse Benet's position because Jesse has left. I'm so sad about that. Jesse's so fabulous. Real loss for the agency. Yeah, so Sam is interim in that position, and that position sits directly under Ebony. Yeah. And then that position supervises Nicole. Yeah.
So adult mental health head honcho supervises Nicole.
Yeah, because they're adult behavioral health.
Okay.
So they do SUD and mental health.
And this Nicole's, I get so confused because the org charts change, but Nicole is responsible for SUD, right? On the
Yes.
behavioral health side.
Yes.
Okay. And then the position where Sam is now is responsible for all adult behavioral health, including mental health and SUD.
Yes.
And
then
Ebony's
reports directly to Ebony. So Ebony's reports would be Sam is interim. Chelsea Holcomb, I believe, is the youth, and any other division. So there's, I know the tree is constantly changing, but in my head, that's how I'm kind of imagining.
So is Ebony leading all of health systems?
No. Ebony is just she is so it would go whoever, Dave Baden is interim. I'm not sure. We thought that Ebony would report directly to that position. Still the case. Okay.
Yes.
There was a policy person in a meeting who said something different, but I think they were confused. So my understanding is it's Dave Baden as the director of OHA, then Ebony now as the director of behavioral health reports directly to the director. Then there's other C-suite level people equivalent to Ebony, like policy and other things.
Mhm.
And then under Ebony is like Chelsea, the policy, Jackie Fabric. Is Jackie equal to Ebony or under Ebony?
I've heard Jackie is Ebony's like deputy director for behavioral health.
Oh, she's the deputy. Okay.
That's what I've heard. And I will agree, Heather, the tree has many limbs and branches, and I'm still trying to figure out the OHA organizational structure myself. But here's what I think it is. That behavioral health director, who is Ebony Clark, sits within the health systems division, but she is a direct report to the director, so to Dave Baden.
Oh, interesting. And he's no longer interim, right? I saw on LinkedIn yesterday or something that he's permanent. Is that accurate?
My understanding is Dave is filling that position while the governor's office does a national search for a new health authority director.
Okay.
So perhaps I would say he is the permanent interim while they look for a permanent director.
Got it. Okay. So who is the head of the health systems division?
It is
Just
the
has.
person. It is the person who replaced Margie Stanton. It is,
Shauna?
yes, Shauna. Thank you.
Okay.
Heather, you just said something, it's a little off the topic, but I want to be really quick. Behavioral health, when behavioral health is referenced in the OARs, that includes SUD.
Yes.
That's interesting because the QMHP and QMHA, they've been tweaking the OARs, and they don't say state-approved mental health agencies anymore. They say state-approved behavioral health.
Yes, they're changing. They want to change everything
So
to
that-
co-occurring. Yeah.
Yeah, that would mean that QMHAs and Ps can bill at an SUD clinic. And that's
I
huge.
hope. I hope.
I mean, if that's the word, because I saw it today as a man, I'm like, that's not right. That's interesting.
Yes.
Make a note
Yes.
of it.
Behavioral health. We here at OCBH, we've been supporting anytime we can in the OARs that behavioral health is defined as substance use disorder and mental health.
That's wonderful. Well, then next we need a co-occurring certification.
That's the hope. Well,
That's the hope.
we do have the co-occurring pilot.
Yes.
So yeah. So I think
Alright.
it's like we're hoping to lay the staircase for the right trajectory.
Interesting.
yeah.
Okay. Thank
So many things. Yeah, it's very exciting. But again, why having a common tool like ASAM across all the system components, it has so many benefits if we can find the training gaps. Okay. Any other
That's
training
good.
gaps or anything else on ASAM that people have heard about or know anything?
I was going to ask you a quick question on ASM if I could. So I found this this tool. I'm wondering if I found the one that you're referring to. It's like 30 pages long or so. It's got like 6 dimensions in it.
Mhm.
The ASAM Criteria Assessment Interview Guide.
Uh-huh.
Is that okay?
Yep.
That's the one.
Yep.
And
American Society of Addictions Medicine. Mhm.
okay, sounds good. And it sounded like certain groups are required to use this, and we're curious about what other groups that may be using it.
So Oregon has been an ASAM implementation state for about 30 years-ish. And it's in our Oregon rules and statutes for a long time for any community behavioral health provider organization that is certified and audited to meet Medicaid standard. So so anybody who has a CADC, has been working in a community-based agency. If they have a master's, they've also usually have. I had a master's and an alcohol and drug certification when I was practicing. I still have a license for my master's. So it's been a very common practice, and so compared to other states, our clinical on the ground direct service providers are quite well trained and well guided with the system. And then, of course, because it is the American Society of addiction medicine doctors also use that tool very robustly nationwide, more so than other parts of the system nationwide. But here
I
in
think
Oregon
that's why
also.
all the people I work with are addiction medicine specialists.
Yep.
So it'll be interesting. I just sent an email asking the question.
Yeah, but I don't know. Do they use it in the ER with non-addiction? I mean, it's a curious question. So the goal of the SUD waiver, 1115 waiver that was accepted by the feds for Oregon, what was it, Jill, like 2 years ago? 2 years ago. Well, they that required that all of the system parts, that all of the entities that make up the continuum of care get aligned with ASAM, and that we have to report back to the feds how we're training and getting everybody on the same tool across the state, from the payers through all of the different types of providers. In a very brief explanation. Does that make sense?
It does. Thank you. And then when someone mentioned SUD, I got to thinking, I very quickly skimmed through it, but it didn't seem like there was a SUD diagnosis portion of that. Is that?
Yeah, it is.
Separate?
Yeah, that's in the full assessment, and the ASAM folks will tell you there's there is a difference between a full assessment and a full ASAM. ASAM is really can lead to assessment, but it is really a tool for level of care placement.
Okay.
I think I said that right.
Thank you. Thank you.
Right, 'cause isn't it in most places a condition, like you can't enter residential treatment in a Medicaid facility without the ASAM, right?
That is correct in Oregon.
Okay.
Yeah, for 30 some odd years. Yeah.
But you could go to Hazelton or someplace like that without an ASAM, probably.
You could, but I think they even use ASAM, honestly. I think it's such a common practice in a lot of commercial insurances because it's the most
Okay.
robust tool. They even tend to use it. Like I said, there's just some physical health settings that still use a couple other tools more so. There are other tools that other SUD professionals use, but ASAM is the most predominant tool. Good questions. So yeah, that's what I know about that, and so they're trying to find, so since we have to, because CMS gave us approval, but that's one of the reporting items. I know that's what the OHA team is working on, just trying to support them to be successful.
And Nora, did you just get my email?
Sorry, I did. I was just I'm like up on the hill and had
I knew
last
it.
minute NIDA visit. So I didn't send an email saying that I wasn't going to be able to come. Excuse me.
I hope your visit went well.
It actually did go. It went great. Yeah.
Cool. Okay. Well, anything else on ASAM? Or Jill, did you have other questions?
And Nora could answer this question off the top of her head. I think that we've just been discussing.
So can you explain the question?
Sure. We were looking for any gaps as Oregon is trying to lift ASAM, as the Oregon Health Authority, as part of the SUD waiver, is trying to lift ASAM even more robustly across all of the different parties who serve people with substance use disorder, including payers and physical health and community-based and physicians and everybody. They were here in the subcommittee, and then also because of the waiver, the team over at OHA looking for training gaps or places where ASAM knowledge is not as strong. And so we were kind of like, we know addiction medicine doctors, of course, use ASAM. But if there's other intersects, like maybe in the ED or I don't know where, or primary care, where they may not be using that tool, and it would be helpful for them to be trained.
I'm not sure that what I'm thinking of when you say, what do you mean using the ASAM assessments? Like doing a comprehensive social work ASAM assessment? What do you mean?
No, just the ASAM. I'm sorry, I apologize. I'm being using my language loosely. Using the ASAM tool for level of care placement.
So I would say it's very much not being applied in any U.S. hospital or ED. Our our social workers, think about ASAM level of care, but I don't actually think that the general medical social workers know what that means. I wouldn't frame the question quite this way because I don't think it's going to get us the answer that we want. And I'm sorry, that's like a very actually non-helpful or non-specific way of saying, like, I don't know a better way to frame it, but I think it's like a little bit of it's going to be a mismatch. So I think though, like is the question, I guess I need to understand the question a little bit better, and we don't have to use the time right now to do it, but I don't think that, I think that there's critical gaps to improving hospital and ED care in Oregon but I wouldn't say that one solution is for them to know how to do an ASAM assessment or understand ASAM levels of care. I actually don't think that would get us any further to better care. Not that it wouldn't, I mean, again, it wouldn't hurt, but I don't think that that's the lever we want to try to pull. And there might be ways to crosswalk if there's a separate reason that we need to point out to whomever, to regulators or others, that we can sort of embrace ASAM principles. We could think about how to do that, but describing it as hospitals doing ASAM assessments or making recommendations around ASAM level of care feels like both unattainable and not necessarily where we should be emphasizing.
Would
You answered the question perfectly.
Okay.
I'll tell you the conundrum. Oh, sorry, Christy, and then I'll let Christy go.
No, go ahead. I'll follow up. You might answer it.
Yeah, so the conundrum is because the Oregon Health Authority in the SUD waiver, part of what was approved by the feds for the Medicaid plan through the SUD waiver is that that ASAM utilization across the diverse system of care, so diverse system of care that serves Medicaid consumers, more robustly use the ASAM tool to improve systems, I guess, flow of patients and consistency in the system. So because of that, then OHA has made a big task for themselves on kind of evaluating, and I think you answered the question really well. And so I'm going to I had a couple people who are charged with looking at training gaps to fulfill and create a more, how they're going to fulfill this waiver task effectively in a way that's useful, as you just mentioned. So, because that made a lot of sense to me, what you just said, because you don't want to put too much effort if it's not going to robustly get you where you need to go. But at the same time, they have put this into the waiver. Does that make sense, Anera?
It does. Yeah. What I might say is, I think we could say, like, thinking about, again, when we're talking ASAM, you're talking like, are we talking a 3.7 level of care? Is that what I just want to make sure
right. So what they're really looking for in the waiver is they wanted everyone to be using the same level of care language, so it would ease the transition of consumers. That's the really simple way to say it, right? But that's a complicated task.
It is a little bit like square peg in a round hole for hospitals and EDs, because people aren't coming for addiction care, they're coming for other reasons. And so this actually came up in the survey that Liz led too, where the questions were organized around this, and I was sort of a little stuck, but we kind of figured it out. I can't remember who I talked to, but it was a very good person collecting the data. I think that we could pick out pieces of, if we're trying to change clinical care and support training needs, we could say in every hospital, or every hospital clinician or certain, should be able to identify and treat with acute withdrawal. Like, yes, that is not happening. And you could crosswalk that with what that means for ASAM level of care, but I think the screening data in hospital and ED supports that we should not be emphasizing screening in hospital, and yet Oregon Medicaid had a quality measure around that, at least previously. I would largely say we should ditch that, and it's a waste of time and energy and kind of a distraction, because it makes hospitals say and feel like they're doing something, but they're not. Again, that's my...
Yeah, and unfortunately, I think this is probably a continuation of some things that's a little bit like that, but maybe we can, so I'll connect you, maybe long story short on this one is I'm going to get the names of the folks I met with and I'll have Jill send that to you too. So, because I was trying to connect them to Christy, because MACBO has tons of ASAM training available for clinicians of all level and all kinds of stuff. So Christy, did I cover what you were going to say? Or?
Yeah. I mean, in the hospital setting, especially the emergency room, I have to agree. I mean, you'd more likely be referring somebody that they would then do an assessment to see your level of care. And if we could ever get these 110 assessment centers going, that would be great. But yeah, that's what once you said that, it kind of dawned on me that you don't have the time to do that. You don't have, I mean, some hospitals have residential. Yeah.
Like our impact social workers, they can, they got it, no problem. But they're part of a specialty addiction team.
Yeah.
I wonder the ED social workers maybe, but again, it's not really like we have major gaps of our social workers and care managers not understanding how methadone works and how that like you can't just tell somebody anyway.
Yeah.
So in terms of how to make care better, which I know is the ultimate goal for all of us, I worry that it's a little bit of a mismatch.
It's more like the referrals are where you need to be referring, enough knowledge of ASAM, just enough so that you're referring to the right place. Okay, go here. I mean, that kind of thing, but not really assessing. Yeah.
And part of the issue too is that, there's people with vast needs and we don't have the system capacity. Even if they had the right ASAM level determined, it's not available. So why do the assessment if you can't act on it? And I think,
yeah.
That makes a lot of sense. Jill, what do you think? Should we maybe ask Nicole and her team members to come here and talk about this as they're trying to develop their training plan? That's what I'm thinking.
Yeah. Okay. Let me mark it down for another speaker. Now for our document though, Honora and Heather, instead of really focusing on if hospital staff are using ASAM, is it based on the discussion we have, is a better way to phrase that to say, making sure that ED staff have the appropriate training, and some examples I heard were like acute management withdrawal. So instead of focusing so much on ASAM, making sure that if there are training gaps, those are addressed in ED staff. Did that make sense?
Partly, I guess I would say one, I'd be really intentional about which staff we're talking about. So our hospital staff and ED staff are ED staff are part of hospital staff, but if we're really talking hospital staff, we need to talk beyond the ED. I think the opportunities are, I mean, again, this is my bias because my work is hospital focused, but I think that the inpatient piece is huge and really critically important. And I think, there are systems in place. We were in our 13th cohort of a telementoring echo around hospital-based addiction care. So it's not like we would have to start over. And I still am meeting with hospitalist groups as recent as last week saying, offering methadone and bup is in your lane. This is not something that you can, this is part of your practice. There's SHM consensus guidelines now that say this is part of your practice, et cetera. And there's no external incentive and there's no carrot, there's no stick. So I'm not really answering your question, Jill. I'm just kind of on my high horse here, but.
Nope. That is really helpful because I know our meeting is going to end here in just a couple of minutes. So I think what I'm going to do on this one is just say there's more discussion that we're going to have on this because I don't see that we're going to land on perfect wording of what exactly we want to see happen in the next 3 minutes. And it feels like there's still a lot more to delve into on this topic. So I'm just going to say more discussion on this topic about possible training gaps of hospital staff, and we're going to talk more about what that even means.
That sounds
Honoria,
great.
Before we go, so when you go on your sabbatical, who's coming instead of you? Who are you assigning?
No, I'm happy to recruit somebody.
Okay.
Yeah, I'm happy to recruit somebody for sure.
Yay.
I really love
I was
this
like,
meeting,
oh no,
but
she's
it'll be-
leaving soon.
It'll be really late where I am, so this is like one that I would try to come to, but I think it's gonna be my bedtime, so.
I bet
Probably.
Dan Hoover would love it, and Nora. I think he'd be great.
Oh, good idea. Great idea.
And I guess I do have to make room for public comment. Is that a part of my duty?
Yes, I'm gonna take us off screen sharing, and I'm sorry, everybody, your eyes are probably gonna cross on this for just a second, but just hold on. And we're gonna go off screen share. There you go. And yes, it is a requirement for having a public meeting that we make sure there's opportunity for public comment. I don't believe that we have any members of the public though, but you can do a shout out just to make sure.
All right, so if there are any members of the public who would like to make comment, please raise your hand. I see no hands raised, Jill. Okay.
Then I think we're good.
Okay. Well, we're getting close to the end of the amazing document, and boy, we're learning a lot. Thank you guys so much for all your sharing, and this is super interesting and exciting. I think we're going to have a great plan by the time we're done with this and know a lot more about what's happening across the system of care. I really appreciate everybody so much. So super cool. All right, well, that was my first. I hope I did okay. That was my
That
my
was
first
awesome,
day.
Heather. I learned so much today. It was like a class.
Well, we got some really smart people here. It's really impressive. We're doing impressive things. Not only are they smart, they're doing cool stuff. So thank you all so much for making it on a different day and accommodating my schedule. I apologize for that. And thank you all for your time here. So anything else for the good of the order, Jill, or are we done?
I think we're good.
Okay. All right. Thank you, everyone.
Thank you. Sorry I was
Bye.
late. Liz, thanks for that email.
No
Yep.
problem. I'm glad you
Bye.
hopped on.
Perfect.
Bye.